In this lecture, we're going to talk about thrombocytopenia. It's an enhanced version of the lecture you see in the 3rd and 4th year clerkship videos. We're going to engage more the pathology and also the clinical presentation of these diseases, and you're going to recognize how easy they are to spot from one another. Let's start off by comparing TTP to DIC because often people have difficulty discerning one from the other. Before we do that, we have to review primary and secondary hemostasis. Primary hemostasis is all about the platelets. And you remember they go through adhesion, activation, and aggregation. That results in the formation of a platelet plug. That platelet plug is held together by fibrinogen and is tethered down to the endothelium by von Willebrand's factor. Glycoprotein 1b grabs onto the von Willebrand's factor. Glycoprotein 2b3a links the fibrinogen to platelets. But the whole point of this platelet plug was to create substrate, fibrinogen, at the site of endothelial injury such that the clotting cascade can turn fibrinogen into a fibrin clot. But the body's not stupid. It's not going to allow fibrin clots to exist everywhere, so it is going to make plasmin to degrade fibrin into D-dimers. Secondary hemostasis was all about the factors. But we don't measure factors in the blood. Instead, we use other blood tests to discern what's going on with the clotting cascade. We're going to use the PT, the PTT, and the INR. And you've noticed that some of these things are listed in green. These are going to be the tests that separate DIC from TTP. Let's talk about each of those diseases and come back to this picture to decide what the most likely thing is going to be of these values, up or down. Let's talk about DIC first. DIC is the formation of a fibrin clot in a blood vessel with little Wolverine claws coming out. The problem with DIC is that it is fibrin clots that form everywhere such that they form where they shouldn't, and they use up all of the product so they can't form where they should. The patient presentation is going to be sick as shit. This person is someone who's going to be in the hospital for a long time with something else, like gram-negative rod bacteremia, someone who's in intensive care unit for something else, end-stage liver disease. This person is going to be very, very ill. They get tipped into DIC, and then they start bleeding. They bleed from every hole. They bleed from every IV site. This is the person you put a central line in, but you cannot get them to stop bleeding even though you've held pressure for 30 minutes. You think they have DIC, so you attempt to diagnose it. The way you diagnose it is with a DIC panel. Not surprisingly, what we talked about in the beginning ends up in the DIC panel. It's platelets, fibrinogen, D-dimer, and PT, PTT, INR, as well as a blood smear assessing for schistocytes. And this is why I bring it up. Schistocytes in both DIC and TTP, so people aren't sure how to handle the schistocytes. Let's work through it and see if it makes sense. In DIC, they're going to use up everything in order to make fibrin clots. So the platelets are going to be consumed. So the platelets will be down. Fibrinogen will be used to turn into fibrin. The body's not stupid, so the excess fibrin will be turned into D-dimers. The factors are consumed as secondary hemostasis is constantly utilized. But we don't measure the factor levels. We measure the PT, the PTT, and the INR, the coag panel. And as the factors go down, these go up. And because of the microangiopathic hemolytic anemia from the Wolverine clause, you have a positive blood smear for schistocytes. The treatment for DIC is to treat the underlying disease. And you do give product. If the platelets are low, you're going to give platelets, generally in the form of a 6-pack. If the fibrinogen is low, you're going to give cryo. If the factors are low, you want to give factors. That is going to be fresh, frozen plasma. And if their hemoglobin is low, you're going to give them packed red blood cells. This is a little taste of why you give which product. Fibrinogen low, give cryo. INR up, give FFP. Platelets low, give platelets. If hemoglobin's low, give blood. But the most important thing to remember about DIC is to treat the underlying disease. Let's compare that to TTP. TTP is the formation of hyaline clots, and they're like piano wire, monofilament wire across the vessel. The pathology is hyaline. And since they've got this monofilament wire, what happens is that any blood product that flows through gets sheared. You probably remember from medical school, the patient presents as a fat RN. That is to say, fever, microangiopathic hemolytic anemia, thrombocytopenia, renal failure, and neurologic symptoms. But I want you to pause and think about that for a minute. If you spent any time in the ICU, how many of your patients were intubated and sedated who were in renal failure where you were considering getting dialysis involved, who had a thrombocytopenia and a microangiopathic hemolytic anemia and were febrile because of their sepsis? The person in DIC may also be a fat RN. And so using this alone isn't useful. Let's talk about the difference in the DIC panel first, then talk about the difference in the clinical presentation. The diagnosis is going to be made by getting a DIC panel. Platelets, fibrinogen, PT, PTT, INR, and schistocytes. The thing about TTP that makes people confused with DIC is the fact that the platelets are down and there are schistocytes. There is microangiopathic hemolytic anemia and thrombocytopenia. Thus, you cannot use the platelets to distinguish DIC from TTP. But get back to the pathology. TTP is a hyaline clot. So if I asked you, does primary hemostasis occur in the formation of a hyaline clot? You should say no. Is the substrate for hyaline fibrinogen? No. So fibrinogen is normal because it won't be used up. In the clotting cascade, do we ever mention the word hyaline? No. So in the formation of a hyaline clot, PT, PTT, and INR are normal because factors aren't used in the creation of a hyaline clot. The difference is in the pathology. Fibrin clots use up the clotting cascade, hyaline clots don't. And it's also very important to the treatment because the treatment for TTP is an exchange transfusion. and you never transfuse product. Because if you transfuse platelets, you make the microangiopathic hemolytic anemia worse. So differentiating these is very important. DIC is give them product and hope the underlying condition gets better. TTP is never give transfusion of products and give them an exchange transfusion instead. TTP is a product of Adams TS13. Don't worry about it. What I want you to be able to distinguish is a clinical presentation of DIC versus TTP and confirm it with the DIC panel. See DIC as the person who is sick already. They are on the vent, they are near death, and oh, by the way, now they're in DIC. The person with TTP is the person who's going to walk in and say, hey, I'm not really sick yet, but I'm getting there. The person who walks in normal all of a sudden develops a stroke and renal failure and some petechia. They don't have anything else going on. You haven't diagnosed them with sepsis or ARDS or a massive GI bleed. They're the person who walks into the ED and says something's wrong, TTP. The person who gets brought in by the ambulance is already obtunded, sedated on pressors, has DIC. Fat RN works great for the boards because the test is going to tell you the person is terribly ill, who is a cirrhotic, who's waiting for transplantation, and they're in DIC. But in real life, Fat RN is both in TTP and DIC, and you have to use the overall picture and the DIC panel to separate them because the treatments are very, very different. This is the most complicated topic in this lecture. Let's talk briefly about heparin-induced thrombocytopenia and immune, formerly known as idiopathic thrombocytic purpura. HIT is about the antibodies. And so antibodies to heparin that cross-react and destroy platelets. The patient is going to be someone who is in the hospital, drop in their platelets. There's two ways this presents in reality. It's going to be the patient who happens to be in the hospital for a long time and their platelets drop. And you're going to be following their platelets every day because they're on heparin. And you say, wow, their platelets went from 250 to 125. That's weird. What's up? And the discussion is going to be, ooh, does this person have HIT? Because they've been there so long. The other way is you're going to have someone with a clot who gets placed on heparin and the clot worsens. Again, in a clinical reasoning sort of way, this person is not nearly as ill as TTP or DIC. This person happens to be in the hospital for something else, and you notice a drop in their platelets. And because the treatment is actually pretty severe, you have to switch to another medication like argatroban or lepirudin and bridge them to Coumadin to fix their clot, which are very expensive. And the send-outs for the diagnosis of HIT take a long time to come back. You're going to spend an awful lot of time discussing with your attending and your team, is this HIT and do I need to pull the trigger on this other medication? Well, it turns out that there's a scoring system that got developed in order to help you make that decision. It's the 4 T's. That is in the timing, the presence of thrombosis, the degree of thrombocytopenia, and whether or not there is an alternative diagnosis. This is not my mnemonic, it just exists. And you get 2 points, 1 point, or 0 points in each section. And then if you have 4 points, just consider it HIT. The timing goes like this. You get 2 points if it occurs between 5 and 10 days. That is the natural course of HIT. Someone who is not exposed to heparin previously gets exposed, and then on day 5 or 10, the prolonged stay, their platelets drop. If it's more than 10 days, that's taking too long, they only get 1 point. And unless they have been exposed previously to heparin in the last 100 days, if it is sooner than 5 days, they get 0 points for HIT. That is to say, it takes about 7 to 10 days for the antibodies to develop unless you've been exposed previously, in which case, if you've been exposed, 1 point. For thrombosis, if you have a new thrombus formed while on heparin, that's 2 points. If you have an extension of an old thrombus while on heparin, that's 1. And if there's no thrombus or no worsening of the current thrombosis, you get 0. The degree of thrombocytopenia matters a lot. You should lose greater than 50% of your platelets, but the nadir should not go below 100. You lose a lot of them, but you don't go that low. And that's critical to HIT. It very rarely drops the platelets into double digits and will never drop platelets into the single digits. It's a strong statement, never, but the idea is that with HIT you should not get very low, and if you have super low platelets, you should think of something else. If it's only a drop of 30 to 50%, then you get 1 point. Less than 30% drop, no points. And for alternative diagnosis, if there is no alternative diagnosis even being considered, you get 2 points. If there's one that's acceptable, you get 1 point. And if there is clearly an alternative diagnosis, you get no points. So I want you to look at this chart all at once. The typical heparin-induced thrombocytopenia is one that presents with a new thrombosis with a drop of 50% from the platelets, but not into double digits, that occurs at around day 7 of hospitalization. If you have any of these elements, it's heparin-induced thrombocytopenia. If it's close, well, maybe it's not, and you have to get all 4 columns in order to get it. The most important thing is the things that exclude heparin-induced thrombocytopenia is a meh drop in the platelets, especially if they are paralleled in the hemoglobin and the white blood cells, that is, yours are simply hemoconcentrated. There's not a thrombosis, and it occurs early. So most of your patients who are in the hospital aren't going to be there long enough to get heparin-induced thrombocytopenia. But patients who were just in the hospital returning with low platelets and maybe a new thrombus are the ones you should really consider for heparin-induced thrombocytopenia. You'll very rarely see HIT in your patient that you admitted. You will see them in people who return to the hospital after a couple of days of being released. The treatment for heparin-induced thrombocytopenia is to bridge them either with lepirudin or argatroban, the 10A inhibitors we learned about in the bleeding lecture, and bridge them to Coumadin. The specifics of this process are beyond this lecture, and you can look it up. Once you've made the diagnosis with HIT and send off hit antibodies, you immediately start them on lepirudin or argatroban and bridge them to Coumadin, because they're going to have risk for thrombosis. This is more detailed, and it's where HEMONC comes in. Your job as an internist ends with a diagnosis of HIT. And finally, we're going to finish up with the easiest one of all, immune or idiopathic thrombocytopenic purpura. The pathology is unknown and thought to be immune. The patient is going to be essentially asymptomatic with extremely low platelets. If you see single-digit platelets, that's either chemotherapy or ITP. Now, is this always true? Of course not. But immune thrombocytopenic purpura is a diagnosis of exclusion. So you will have ruled out all of these other diagnoses first. The diagnosis is made by exclusion and is often suspected when the platelets are extremely low and the patient is presenting with purpura or petechia because of those low platelets. What's interesting is that these patients generally do not bleed into their brain, even though their platelets are very, very low. So upon first presentation, you can consider giving them platelets until they've ruled out other diseases. Make sure it's not TTP, because platelets will make them worse. But to fix the condition, you have to reverse the immune component. To do that, you use corticosteroids. Acutely, you can give IVIG or Rogam. If the patient is refractory to these medications, you can cut out their spleen, because we think the spleen is where all the damage is being done. Antibodies attach themselves to platelets and the spleen eats them. We're not sure. And long-term therapy with the monoclonal antibodies like rituximab come into play. I'm being very overview only for ITP because if you understand the pathology of the other diseases, you'll be able to clinically reason into or out of them very quickly. Once you've said it's not the other causes of platelet destruction, but they've got petechiae and a very low platelet count, and they're not on chemotherapy, you call hem-onc and say, I think it's ITP. Your job as an internist ends when you're able to diagnose ITP, and they're going to come help you manage it. Whereas the others are going to be up to you to make sure that what type of condition they're in, and maybe even start an immediate therapy to save their life. If you can understand DIC, TTP, and HIT, understand them in great depth, ITP is a diagnosis of exclusion, and unless you're going into hematology oncology, you don't need to know that much about it. That is thrombocytopenia. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.